this cleaning sponges and antiseptic solutions before this procedure to avoid post-lumbar puncture infection. And I will show you how to do this procedure in this model later. And also, you need to do a local infiltration anesthesia using this syringe and 2% lidocaine to infiltrate this area because the lumbar vertebra without local infiltration anesthesia will be very painful for the patient. And after you have cleaned the puncture site and do your local infiltration anesthesia, you can insert your spinal needle through the predetermined lumbar puncture site. So you insert your needle. The needle should be almost perpendicular to the skin of the patient's back, but there should be a small angle. The needle tip should aim for the umbilicus of the patient, so the needle should not be absolutely perpendicular to the skin of the patient's back. This is because the posterior spinous process points posteriorly and inferiorly. So if the needle is absolutely perpendicular to the patient's back, the needle may contact with the spinous process before entering the spinal canal. Also, during the insertion of the needle, you need to make sure that if you are using the traditional clinking needle, you need to put the cutting edge face upward or face downward. So this cutting edge should be parallel with the fibers of the patient, especially parallel to the fibers of the dura mater of the spinal cord. So this will create a small hole in the dura mater of the spinal cord of the patient, and this will prevent the post-lumbar puncture headache. If the cutting edge is vertical to the fibers of the patient's dura mater of the spinal cord, the needle will cut a large hole in the dura mater, and this hole will cause severe post-lumbar puncture, cerebrospinal fluid leak, and severe post-lumbar puncture headache. You should always keep the spinal needle in the midline of the patient's back. And as I said earlier, when your spinal needle enters the spinal, before your needle enters the spinal canal, your needle tip will contact with this yellow large ligament or ligament of labor. And at this moment, you feel a lot of resistance because this yellow ligament is very thick and very tough. You will feel a lot of resistance before the needle enters the spinal canal. And here you should be very careful because when you advance the needle for 1 or 2 more millimeters, the needle tip can pierce through the yellow ligament and enter the spinal canal. Now it is very probably that the needle tip is now in the epidural space. And you should be very careful because you advance the needle for 1 or 2 millimeters, the needle tip will pierce through the dura mater of the spinal cord and enter the subarachnoid space. And at this moment, you will find some cerebrospinal fluid flow out from the spinal needle. And this confirms that the needle tip is now within the spinal canal in the spinal cord, in the subarachnoid space. And at this moment, you can connect the pressure manometer with the spinal needle using this three-way stopcock. And you will see the cerebrospinal fluid flow from this spinal needle into this pressure manometer, and when the fluid level reach equilibrium, you will read out the pressure, and this will be intracranial pressure. After the pressure measurement, you can collect some cerebrospinal fluid specimen for laboratory test using these 3 or 4 collecting tubes. And after the specimen collection, the procedure is finished. You can protect this puncture site with some tape, and you ask the patient to lie in their bed for rest for 3 to 8 hours. And the lumbar puncture is associated with some complications, and most of the complications are mild complications, including the headache and back pain, as I talked earlier. But some are very major, severe complications, including infection, bleeding, cerebrospinal, the cerebral stimulation, and spinal cord injury. To prevent this severe complications, you need to rule out the contraindications before you do your procedure to the patient. You need to read the re-imaging results before lumbar puncture to make sure that the patient do not have an intracranial lesion with mass effect or any abnormal intracranial pressure. You also need to check the platelet function, the platelet count before doing this procedure to make sure that the patient do not have any bleeding disorders. You also need to check the medication history of the patient to make sure that the patient is not taking any antiplatelet or anticoagulant therapy right before this procedure. And you also need to know some risk factors for mild complications, including post-lumbar puncture headache and post-lumbar puncture back pain. Some of the most important risk factors, including younger age, female sex, history of headache, and fear or anxiety before the lumbar puncture. So if the patient meets one or more of these risk factors, the patient is at high risk of post-lumbar puncture headache. So to reduce the likelihood of post-lumbar puncture headache, you can choose a smaller needle, especially a needle with a small diameter and atraumatic needle tip. And so you choose a proper needle. This will decrease the risk of post-lumbar puncture headache and back pain. You also need to make sure that the failed attack should be less than 4. So if you are not very familiar with the lumbar puncture and you have failed twice, you need to ask for help. And also you need to avoid withdraw the cerebrospinal fluid with your syringe, because if you apply some pressure to withdraw the cerebrospinal fluid with syringe, it will create a large decrease of intracranial pressure and increase the risk of post-lumbar puncture headache. And you also need to make sure the patient take a lateral recumbent position instead of a sitting position, because in the sitting position, the level of the patient's head is higher, so the pressure will be lower, the risk of headache will be higher. And you should not collect too much cerebrospinal fluid. Usually 30 ml is okay. I think I've finished the introduction of some theories of the lumbar puncture, and so we're going to show you how to do this procedure in this patient. But before that, I would like you to watch a video recorded by the New England Journal of Medicine in 2006. And this shows how to do the lumbar puncture properly. It's a 10-minute video, and you can read it. You can watch it, and if you are going to need some rest, or you need to use the restroom, you just go there.
This is a video in clinical medicine from the New England Journal of Medicine.
This video will demonstrate safe and successful methods of performing lumbar puncture. Lumbar puncture is indicated for both diagnostic and therapeutic purposes. Also, the administration of spinal and epidural anesthesia involves the use, essentially, of the same technique. Analysis of cerebrospinal fluid may be helpful in the diagnosis of infectious processes such as meningitis, inflammatory diseases such as multiple sclerosis, cancers such as leukemia, and metabolic processes. Therapeutically, lumbar puncture allows for the intrathecal administration of chemotherapeutic agents and antibiotics. There are specific contraindications to lumbar puncture, The condition of patients with cardiorespiratory compromise may worsen as a consequence of the position they need to assume for lumbar puncture. The procedure should also be avoided in patients with signs of cerebral herniation, incipient herniation, or increased intracranial pressure, and in those with focal neurologic signs. In such patients, cranial CT should be performed before lumbar puncture, although CT may not reveal signs of increased intracranial pressure. Finally, there is an increased risk of a spinal hematoma if a coagulopathy is present or if the patient is receiving anticoagulant therapy. Patients who have previously undergone lumbar surgery should be referred to an interventional radiologist. Before performing the lumbar puncture, you will need a commercially available tray containing the necessary supplies, a spinal needle with a stylet, equipment for skin preparation, drapes, collection tubes, and in some cases, a manometer. Typically, a 20 to 22 gauge needle is used, with the length ranging from 1.5 inches or 3.8 centimeters for infants to 2.5 inches or 6.3 centimeters for children and 3.5 inches or 8.9 centimeters for adults. You will also need sterile gloves. Before you begin, you should explain the procedure along with potential risks and benefits to the patient and obtain informed consent from the patient or his or her parent or guardian. After obtaining appropriate patient consent, the patient is positioned. Either the lateral recumbent position or a sitting position can be used. The lateral recumbent position is preferred to obtain an accurate opening pressure and to reduce the risk of post-puncture headache. Instruct the patient to assume a fetal position or to arch like a cat with the back flexed. This position widens the gap between the spinous processes. Ideally, the lumbar spine should be perpendicular to the table if the patient is in the sitting position and parallel to the table if he or she is in the lateral recumbent position. These positions help keep the needle at the midline. A line is visually drawn between the superior aspects of the iliac crest and intersects the midline at the L4 spinous process. Insert the needle in the interspace between L3 and L4 or L4 and L5, since this location is below the termination of the spinal cord. Palpate the landmarks before preparing the skin and before administering local anesthesia, since the anesthesia may make landmarks harder to identify. Use a skin marking pen to identify the site of needle insertion. While wearing sterile gloves, clean a sufficiently large area of the overlying skin with a disinfecting agent, such as chlorhexidine or providone iodine, using a pattern of whitening concentric circles. Drape the area with sterile drapes. Lay out the collection bottles in the order of priority for the diagnostic indications. Lumbar puncture is a painful and potentially anxiety-provoking procedure. At a minimum, the use of a local anesthetic is appropriate. Sedation or systemic anesthesia may be required under some circumstances. You can apply anesthetic cream topically before preparing the skin. After preparing the skin, you can inject local anesthetics subcutaneously. Identify the anatomical landmarks once again and insert the needle with stylet firmly in place in the midline at the superior aspect of the inferior spinous process, directing it at an angle of approximately 15 degrees, as if aiming at the patient's umbilicus. Either use a pencil-tipped needle or assure that the bevel of the needle is in the sagittal plane so as to spread rather than cut the fibers of the dural sac. These fibers run parallel to the spinal axis. The use of this needle position should theoretically decrease the leakage of cerebrospinal fluid. If properly positioned, the needle should pass through the skin, the subcutaneous tissue, the supraspinous ligament, the interspinous ligament between the spinous processes, the ligamentum flavum, the epidural space, including the internal vertebral venous plexus, the dura, the arachnoid, into the subarachnoid space and between the nerve roots of the caudate point. As the needle passes through the ligamentum flavum, you may feel a popping sensation. Once you have reached this point, the needle should be advanced in 2 millimeter increments and the stylet withdrawn after each increment to check for CSF flow. If no fluid is detected and bone is encountered, withdraw the needle to the level of subcutaneous tissue without exiting the skin and redirect the needle. Fluid will flow once the needle enters the subarachnoid space. If the lumbar puncture is traumatic, the cerebrospinal fluid may be tinged with blood. As additional fluid accumulates in the barrel, the fluid should become clear, unless the source of the blood is a subarachnoid hemorrhage. If the flow is poor, a nerve root may be obstructing the opening of the needle, and you should rotate the needle 90 degrees. If drops of blood enter the needle, it may become clogged. In this case, you should obtain a new needle and enter the site through a different interspace. For you to obtain an opening cerebrospinal pressure, the patient must be in the lateral recumbent position. Use a flexible connector and attach a manometer to the hub of the spinal needle. After waiting for the column of fluid to rise, and possibly seeing pulsation from cardiac or respiratory motion, you may take a measurement. If the cerebral spinal fluid pressure exceeds 25 centimeters of water, you should closely monitor the patient for signs of herniation and determine the cause of the patient's elevated intracranial pressure. You must allow cerebrospinal fluid to drip into the collection tubes. Never aspirate cerebrospinal fluid. Even a small amount of negative pressure can precipitate a hemorrhage. The amount of fluid collected should be limited to the smallest volume necessary for testing. Typically, 3 to 4 milliliters of fluid is sufficient for routine indications. By turning the stopcock toward the patient, fluid in the manometer may be collected. After collecting an adequate specimen, replace the stylet and remove the needle. Although traditionally patients have been told to lie flat for several hours after a lumbar puncture, there is no evidence that this precaution decreases the risk of a cerebrospinal fluid leak, post-puncture headache, or other complications. All sharps should be properly disposed of in appropriate sharps containers or needle lock devices to help minimize the risk of needle stick injury. Obese patients may represent a challenge due to difficulty in identifying landmarks. Other conditions, such as osteoarthritis, ankylosing spondylitis, kyphoscoliosis, previous surgery that has altered landmarks or spaces, and degenerative disc disease also may make the procedure more difficult. If faced with these challenges, consider consultation with an anesthesiologist or perhaps a radiologist, if fluoroscopy-guided lumbar puncture seems to be a better approach. Lumbar puncture has numerous possible complications, including cerebellar herniation, referred pain, headache, bleeding, infection, the formation of a subarachnoid epidermal cyst, and leakage of spinal fluid. You can avoid many of these complications by conducting a careful assessment of the patient before the procedure, including a thorough neurologic examination and retinoscopy, and monitoring the patient throughout the procedure. A subarachnoid epidermal cyst occurs when a skin plug is introduced into the subarachnoid space. The standard use of a needle with a stylet will avoid this complication. Leakage of spinal fluid can occur at the puncture site. A large bore spinal needle is more likely than a smaller bore needle to produce a leak, so the latter should be used whenever possible. In the case of persistent leakage of spinal fluid, an anesthesiologist should be consulted to determine whether a blood patch is needed to occlude the leak. Lumbar puncture is a commonly performed procedure and be a very useful aid in clinical diagnosis and treatment.
Okay, we are going to show the procedure in this order. doctors for this patient. Before we approach this patient, we need to review the patient's medical record to make sure that this patient this patient has indications of a lumbar puncture for diagnostic purpose or treatment purposes. And also we need to make sure that the patient do not meet any of the contraindications for lumbar puncture. And also, before we approach this patient, we need to wash our hands with soap and water. We need to wear a mask and a hair covering before meeting this patient. After we meet with the patient, we first introduce ourselves and ask the patient if the patient is feeling any discomfort or if the patient are going to use the restrooms before receiving any procedure. And then we can position this patient to prepare for the procedure. And we need to tell this patient to bend his back forward and to lower his head to make this the chin and as close to the thorax as possible, and ask the patient to flex this side to make sure that the side is as close to the abdomen as possible. So the patient's back is like a C, letter C, or a small cat, a small infant. And this will increase the space between the vertebra and make sure that the needle insertion is easier. And after the patient has positioned properly, we need to palpate the patient's pelvis to determine the puncture site. And we palpate here, you will feel a bone structure, and you draw a line from this superior posterior iliac crest vertical to the cervical bed or to the floor, and this vertical line will intersect with the midline of the patient's back in the L3, in the L4, here L4 lumbar vertebra. Here is the spinous process of the lumbar vertebra. So the proper puncture site is the intervertebral space above this L4 in the L3, L4 intervertebral space, or below the L4 in the L4, L5 intervertebral space. So these two puncture sites is okay. Also, this L2, L3 is also okay, but you should never perform this spinal puncture or this lumbar puncture above the L1. You should never perform the lumbar puncture above the L1 because the patient's spinal cord ends at the L1. You do not want to injure the spinal cord using your spinal needle. So now the patient has been properly positioned. We need to check our tools. We are going to use some tools that I show you in the PowerPoint. We are going to use a lumbar puncture kit. And before we use this kit, we need to make sure that this has not been opened by anyone else. And this should not be expired. But here, this package has expired. We should not use this package in clinical practice. But we are going to use it for this stage today. We open this package and take it out. When you open your package, you need to make sure that your hand should only touch the outside of this package. You should never touch the materials inside this package before you wearing the sterile gloves. And also you need to prepare by yourself with antiseptic solutions. Here is a bottle of iodine and chlorhexidine. You need to prepare by yourself. Some cotton balls, some tape. You need to find a vial of lidocaine, but we do not have any lidocaine here. But in clinical practice, you need to find about 2% blood. We are going to wear this sterile gloves. And you need to make sure that you should never touch the outer side of this glove while you very poor quality. Okay, we will check again the tools inside this package. This is a drape, some gauzes, some tape, and this is a paper shelf that you can hold the CSF section tubes in this shelf. Like that. This is a typical spinal needle. It's a cutting edge, crinkly needle. It's for adult patients. It's 8 to 9 centimeters long. Here we found some cotton balls and this clamp. This is a pressure manometer. And we also found some syringe. Okay, we need to ask our assistant to provide us some lidocaine and antiseptic solutions. So pour some. This is antiseptic solutions. Iodine and oxygen into this bottle. Yeah, for this. Okay. Now we are going to prepare the puncture site using this clamp, cotton ball, and this antiseptic solution. We have determined that this is the planned puncture site. So we start with this puncture site, and we draw circles using this cotton ball. And we draw these circles, and each circle should overlap the previous one, so you should not leave any areas in the skin unclean. And you draw a larger and larger circles. And the outer side of this, the distance between the outer margin of this side of this circle should be at least 15 centimeters away from the puncture site. And the skin preparation should be performed at least twice. Usually we do this 3 times. And then we are going to do a local infiltration anesthesia. We assume that we have some antiseptic solutions in this syringe, and we are going to before we do this local infiltration anesthesia, we need to do this. We need to use this drape to protect the clean skin. Just like that. You should not allow anyone else from touching this area. Now we are going to do the local infiltration and anesthesia. We insert the needle at the puncture site, just like this. The needle should be almost parallel to the skin, but there is a small angle, usually 10 to 15 degrees. And here we inject some local anesthetics, 2% lidocaine, for example. Here we inject some lidocaine, and we will see the rise in the skin. In the skin, we will create a veil, a skin veil. And after we creating this skin veil, we move our needle, we redirect our needle. The needle should be perpendicular to the skin of the patient, and we insert our needle. This needle insertion will not cause severe pain to the patient because we have already injected local anesthetics to the skin. So here we withdraw. We make sure that there is no backflow of blood because we do not want to inject the local anesthetics directly into the patient's blood. So we withdraw the syringe to make sure that the needle is not in the patient's blood vessels. And we can inject some local anesthetics. And we then advance our needle, withdraw to make sure that there is no blood, and we inject some local anesthetics. And we repeat this procedure for several times until we are satisfied with the local anesthesia. Now we are going to perform the lumbar puncture. We insert our spinal needle. We use our left hand to make sure that this is the puncture site, and we fix the skin around the puncture site, and we use our right hand to hold the spinal needle to insert the needle. So the needle is almost perpendicular to the back, to the patient's back, but there is a small tilt to aim the needle for the umbilicus of the patient to avoid touching the spinal process. And we can insert our needle gently. And here you feel some resistance. Before the needle enters the spinal canal, we feel an increase of resistance because the needle tip has now entered the ligamentum flavor. The yellow ligament is a very tough ligament. It forms the posterior wall of the spinal canal. And here we should be very careful because we advance our needle for 1 or 2 millimeters. We feel a sudden loss of resistance. This shows that our needle has pierced through the yellow ligament and into the spinal canal. At this moment, we check there is no backflow of cerebrospinal fluid. So the needle tip should be in the epidural space without piercing through the neonator of the spinal cord. So we insert our needle for 1 or 2 more millimeters, and we remove the stylet. At this time, there should be some outflow of cerebrospinal fluid because our needle has already entered the subarachnoid space. However, this patient has no cerebrospinal fluid, so you can't find any fluid here. But at this moment, our puncture should be successful. And at this moment, we can measure the intracranial pressure by connecting the pressure manometer with the spinal needle. And you will see the cerebrospinal fluid enter this tube. The fluid will rise until it stops. And when there is no more rise, you read out the numbers. This will be the intracranial pressure. The normal range of intracranial pressure is 50 to 100 to 200 centimeters of water, 50 to 200 millimeters of water, or 5 to 20 centimeters of water. After the pressure measurement, you collect some cerebrospinal fluid samples for further laboratory tests. Okay. After you have done all this procedure, you can gently remove the needle, and the lumbar puncture has been completed. You apply some pressure to make sure that there is no further bleeding around the puncture site. And now you can use this tape to protect the puncture site. You ask the patient to lie in this bed to rest for 4 to 8 hours. And after the procedure, you should drop the waste to a proper site. So this is a contaminated material. It may have been contaminated by the patient's blood. So you drop it in the yellow box. And here is a needle. It's very sharp. You should drop it in this yellow box to avoid hurting others, including this syringe. And you need to send this samples for laboratory tests. Okay, other materials can be dropped in this yellow box, and this has not been contaminated by the patient's blood. You put it in this black box. Okay, I have finished my display of the procedure. Do you have any questions? Okay, we are going to perform this practice.